Hello, I'm Dr. John Leonard, and on behalf of CME Outfitters, I'd like to welcome you to today's educational activity entitled Evaluating the Options, Assessing Emerging Bispecific Antibody Treatments for Follicular Lymphoma. Today's program is supported by an educational grant from Genentech Incorporated. This activity is brought to you by CME Outfitters, an award-winning jointly accredited provider of continuing education for clinicians worldwide. Again, I'm Dr. John Leonard from Weill Cornell Medicine and New York Presbyterian Hospital in New York. Joining me today is Dr. Elizabeth Budde, who is an associate professor at the City of Hope Comprehensive Cancer Center in Duarte, California. Dr. Budde, thanks for joining us today.
You're welcome. Happy to be here.
The learning objective for today's activity is to implement and identify valuable efficacy and safety data for emerging chemotherapy-sparing regimens, which incorporate bispecific antibody constructs. So before we get into the program, we're going to start with a polling question that I will ask of our audience. What is the most common serious adverse event associated with bispecific antibody use for patients with follicular lymphoma? Is it fatigue, diarrhea, peripheral neuropathy, cytokine release syndrome, or I'm not sure? So Dr. Budde, which of these, before we get into our discussion, which of these is the most common serious adverse event with bispecifics?
The most common serious side effect with bispecific is the cytokine release syndrome.
Great. So we'll talk more about that in a few minutes. And this is a very exciting area, as evidenced by the fact that we picked it for the topic of this session. The idea of bispecific antibodies, which really have the potential to make an impact across various B-cell malignancies and other areas. So Elizabeth, why don't you start with explaining to us what is a bispecific antibody? How do they differ from some of the other antibodies that people have been using in practice for lymphoma and other settings?
Sure. A bispecific antibody is a monoclonal antibody, but it's very different than the conventional monoclonal antibody is that, by name, it has two specificities. In most designs are currently available bispecific antibodies involving T-cell engagers are the ones that with two binding sites. As shown here, you can see one of the binding sites really confers the specificity to target. Basically, it recognizes the target on the tumor cell. That's one arm. The other arm, which is the second specificity, really comes to binding to T cells via recognition of CD3. So by pulling the target and the T cell together through this target-dependent recognition, this bispecific antibody is able to really redirect the specificity of the T cell to recognize the tumor cells that express the target. And once the T cells are activated, the T cell will be able to access cytolytic activity, meaning that it will eliminate the target cells.
So over the next few minutes, we're going to discuss some of the bispecific antibodies that are in development. And I think these data are very interesting and exciting. So Dr. Budde, why don't we start with mosunetuzumab, which is one of the antibodies, the bispecifics, as you allude to, that targets CD20 and CD3. Tell us a little bit about those data. And I know you've been very involved in these studies.
Sure. So mosunetuzumab, it's really the bispecific antibody targeting CD20 and CD3 that's been in clinical development. It's the first bispecific antibody targeting CD20 that entered a phase 2 study. It's used as a monotherapy. So in this recently presented data on 90 patients getting mosunetuzumab at the recommended phase 2 dose, all these patients had grade 1 to grade 3A follicular lymphoma. They all had at least 2 prior lines of therapy, including anti-CD20 therapy as well as an anti-alkylator treatment. And most patients in the study, they have refractory disease to last line of therapy. And more impressively, more than half the patients actually had the Part 24, which we know traditionally this group of patients do not do well with conventional therapy. And what we have seen is that the most common side effects, as Dr. Leonard referred to earlier, is cytokine release syndrome, 44% of all grade. But most cytokine release syndrome occur during cycle 1, and a few percentage occur during cycle 2, but all events resolved, and 26% are grade 1, 17% are grade 2, only 1% are grade 3, and 1% are grade 4. And on the right side, you'll see there's a table. This is really looking at, do we see any difference with patient characteristic, meaning that if they have different risk factors defined by conventional definitions, whether this will affect their response to mosunetuzumab, and the answer is really no. None of these subgroup analysis show any inferiority of response. All patients from different subgroups respond equally. The overall response rate is 80% with the complete response rate 60%.
So what about the safety? You touched on a number of the aspects of cytokine release syndrome. Any other side effects that we should be aware of?
Yeah, so safety of mosunetuzumab, has been studied very extensively in the bigger patient population. This really including more than 200 patients with B-cell lymphoma, COVID follicular, DLBCL, mantle cell lymphomas, and in the dose escalation fashion. And again, the most common side effect is cytokine release syndrome, and other commonly seen side effects are hypophosphatemia, patient could have fatigue, and neutropenia has also been seen, but this does not correlate with incidence of infection or febrile neutropenia. So it's actually quite tolerable with very manageable side effect profile. And this drug, nowadays, is given in the outpatient setting. And the way that the current dosing schedule is really to mitigate cytokine release syndrome is by doing the step-up dosing. In cycle 1, the dose is given at a lower dose, low dose, and a full dose on a weekly basis over 3 weeks. And from cycle 2, day 1, it's 1 dose every 3 weeks. This way, the incidence of cytokine release syndrome is markedly reduced. This combo was also studied in patients with diffuse large B-cell lymphomas, and the safety profile looked pretty similar.
So it sounds like this step-up dosing strategy is one that's being used with a number of bispecifics that you'll touch on, including mosunetuzumab. So is the concept just as, say, with obinutuzumab and CLL that people are used to, that they give a low dose initially and then you clear the B cells and have less reaction? Is that the basic concept behind that?
I would say yes and no. Definitely reducing the target is a key. It's a key methodology to mitigate cytokine release syndrome. There are also some unknown factors associated with how T cell responds. Basically, it doesn't matter if the first dose is a low dose or higher dose. The patient will have a pretty similar response, and usually the cytokine release syndrome usually occur during the first and second doses. So by giving the lower dose, we will be able to mitigate the cytokine release syndrome, which allowed us to escalate the dose higher at the full dose.
Got it. So there are a number of combinations that are being explored with mosunetuzumab, as well as some of the other bispecifics as well. Can you tell us about those and kind of why these are rational beyond just kind of sticking it with the usual drugs? It seems like some of these really do have a pretty reasonable biologic rationale.
That's correct. So mosunetuzumab, is currently being tested in combination with lenalidomide. We know this is an immune modulator. On its own has modest effect in B-cell lymphoma. So the idea of combining mosunetuzumab and lenalidomide is really to see whether we can further improve T cell function, in addition to lenalidomide's direct anti-lymphoma effect. So in a phase 1b study, which was also presented recently, the number is small, but we we do see pretty encouraging results. Among the 29 patients treated with relapsed refractory follicular lymphoma after at least one prior line of therapy, the overall response rate is 90%, the CR rate is 66%. And we also see a lower incidence of second release syndrome, around 28%. And the overall grade 3 and above the AEs, this including laboratory abnormalities, is 44.8%. There is a concurrent phase 3 study really comparing mosunetuzumab plus lenalidomide versus the R-square. This is ongoing. It's a global study currently. There are other combinations really looking at the resistant mechanisms of lymphoma cells. If you do monotherapy targeting one target on the lymphoma cells, there's a higher chance for the lymphoma cells to evolve, which we have seen in certain patients. Initially, they responded to bispecific treatment, or they did not respond when we do the biopsies. We do see antigen loss or antigen moderation. So therefore, bringing another targeted therapy, such as polatuzumab, which targets CD79B, we're putting more selection pressure on the lymphoma cells from different mechanism of actions. This way, we will be able to make it difficult for the lymphoma cells to evolve. And this combo is currently being tested in patients with diffuse large B-cell lymphoma, and the complete response rate is somewhere around 50%, regardless of prior CAR T-cell therapies. This really indicates the potency of this combination, and this combination also turned out to be quite safe with even lower incidence of second release syndromes than that of mosunetuzumab alone. And additionally, mosunetuzumab, the one that we discussed earlier, mosunetuzumab is given intravenously. There's also effort further to mitigate second release syndromes by doing subcutaneous injection, which we have seen in phase 1 escalation studies, seeing a delay in the incidence of cytokine release syndrome and also reduce in the incidence.
So next, let's move to a different bispecific antibody, epcoritamab. How is that different from mosunetuzumab? And are those differences significant, at least at this point? Or maybe we can't tell at this point because they haven't been compared head-to-head clinically.
Right. So epcoritamab it's a pretty exciting bispecific antibody. It's also against CD20 and CD3. And similar to mosunetuzumab, it's an IgG-based bispecific antibody. It does have a higher affinity to CD20, and whether this translates into higher clinical potencies, I think it's hard to say. But the current available data on using epcoritamab alone, this is given subcutaneous injection, in a small number of patients with relapsed refractory follicular lymphomas, the overall response rate is quite high, 90%, a CR rate 50%, pretty similar to the phase 2 results for mosunetuzumab, the CR rate 60%. And the second release syndrome incidence, it's a little higher, but not that far off. So I would say based on this data, it's at least quite comparable to mosunetuzumab. And epcoritamab is also being tested in combination with rituximab and lenalidomide. And again, very small numbers, but 4 out of 5 patients had complete remission. 5 out of 5 patients responded. So this is quite high. And we're also seeing a similar trend. There's lower incidence of second release syndrome when you combine epcoritamab with lenalidomide. Really speaks to lenalidomide might be able to help to mitigate the onset of second release syndrome. And side effect profile-wise, it's pretty predictable because it's given a subcutaneous injection. There is 25% of injection site reaction, and there is some adverse events such as constipation, cough, diarrhea, and stomatitis, but none of this is irreversible. So it's quite safe so far.
So what about a third bispecific, odronextamab? This has the characteristic of being quote unquote hinge stabilized. What does that mean? And do we know if that makes a difference?
Yeah, really good question. So this is odronextamab it's also an IgG-based bispecific antibody, like mosunetuzumab and epcoritamab. The ratio between CD20 and CD3 targeting is 1:1. Whether the hinge stabilization contributes to the stability of the antibody, prolong the half-life, or whether it contributes to the potency, we don't know yet. But the preclinical study using this bispecific demonstrated to be quite effective. In the phase 1 studies, as we see on the slides here, you also had pretty high activities in patients with relapsed refractory B-cell lymphoma, including DLBCL and follicular lymphoma. However, when compared to the other two bispecific antibodies, there is a little bit increase of adverse events, especially cytokine release syndromes. There were grade 3 cytokine release syndrome in 6.3% of the patient populations. And the trial was briefly put on clinical hold due to the severity of cytokine release syndrome. And the protocol team subsequently amended the protocol, changed the cytokine release syndrome management, and this trial was reopened. So we don't know yet whether there's increased toxicity associated with this drug. I think time will tell when we treat more patients with this modified cytokine release syndrome management.
So let's move. We have a polling question which highlights a specific issue that after we do the poll, we'll get into a little bit more. These three that we've discussed are CD20, CD3 bispecifics, where they have one binding site for CD20, one binding site for CD3. The results look very high response rates in patients, particularly the group with 3 or more prior therapies. But we're now going to get into the issue of the optimal ratio of CD20 binding sites to CD3 binding sites. And the poll question relates to what is this optimal ratio based on the idea that we could have 1:2, 1 CD20, 2 CD3, 1:1, as we just saw with 1 CD20, 1 CD3, 2:1, 2 CD20, 2 CD20 to 1 CD3, or 10:1, 10 CD20, 1 CD3, or I'm not sure. What does the audience think? Feel free to give us your thoughts as to the optimal ratio is more better. Okay, Dr. Buddy, how would you answer this question, or is there really, do we have an answer at this point? I mean, the idea of multiple binding sites seems like the engineering of these antibodies is becoming quite advanced, and the drug developers are able to kind of add on different moieties. How does that seem to affect things? Yeah,
so this is actually a really good question. I think if I have to pick an answer, I would pick E. I'm not sure. It's just really because we really don't know whether 1:1 is enough. There are many factors that can contribute to the potency of a bispecific antibodies, and this exact question is really being answered by by some newer design of bispecific antibodies.
So let's discuss a couple examples, and probably the one that has the most data of a different ratio is Glofidamab. Which is a CD20, CD3 2:1, 2 CD20 to 1 CD3. Tell us about that molecule.
Sure. So Glofidamab is also anti-CD20 and CD3. So it has 2 CD20 binding sites, so which will definitely increase the ability of these molecules to recognize CD20 positive lymphoma cells, and it has 1 CD3. So based on the clinical results, we know Glofidamab is definitely more potent than mosunetuzumab, and but it also comes with surprise. The toxicity is it's higher than mosunetuzumab. The overall response rate it's around it's 81%, and the CR rate is 70%. So it is 10% higher than mosunetuzumab, but the CRS rate is higher, 66%. And the drug was initially designed to be given as a monotherapy along one dose for every 3 weeks, but subsequently, obinutuzumab was brought in to be given on day -7. The reason is really to help to mitigate the cytokine release syndrome toxicities, allowing the drug to be given safely. And there is also neutropenia, but neutropenia is a pretty common transient side effect associated with other bispecific antibodies. When glofidamab was given in combination with obinutuzumab, this is in addition using obinutuzumab as one dose given at day -7. This is given obinutuzumab cycles after cycle together with glofidamab. We do see there's the CR rate is actually pretty comparable, 74%. Although the overall response rate is 100%, but then you see a much higher neutropenia. So it went from 26% to 58%. So therefore, the study actually currently, for glofidamab is really used as a monotherapy with only 1 dose of obinutuzumab given as pre-dose.
And finally, we have another molecule, IGM-2323, which has an IgM backbone of 10-to-1 CD20 to CD3. This strikes me as something that's quite interesting. What are the data with that and the rationale behind that? Although it's a much bigger molecule, hence IgM.
Yeah, so this is really a very novel platform because the majority of the bispecific antibodies really IgG based, but this is the first IgM based bispecific antibody. So it's a pentamer. It has 10 binding sites. So in this design, this one has 10 anti-CD20 binding sites, so 10-to-1 ratio. And the reason is really that you can pick out the low expressor of CD20 positive cells. And this design in the preclinical setting has also been shown to that unlike the IgG-based bispecific antibodies, it mediates a more physiologic activation of T cells, and hence there's very minimal IL-6 production. So this design, in the preclinical setting, links to a lower inflammatory cytokine production, and it's a good strategy to mitigate cytokine release syndrome. That was the design. And in the phase 1 clinical studies, 29 patients treated with a different histology, including follicular lymphoma patients, DLBCL, mantle cell lymphoma, as well as the marginal zone lymphoma. And initially, it was given as a fixed dosing, so 1 dose every week, because it's IgM, so therefore the half-life is shorter. So it's weekly dosing, and when the dose gets escalated, there is no incidence of cytokine release syndrome, but a lot of it's very hard to differentiate cytokine release syndrome versus infusional reaction. So subsequently, the dosing strategy was changed to a titration dose, basically gave a lower dose and then a higher dose and then the full dose. And this way, only 1 out of 17 patients experienced the cytokine release syndrome after this modified dosing schedule was put in place. And looking at the response rate, this is really looking at patients, again, it's a heterogeneous population, and 8 out of 23 patients responded. 5 of them are follicular lymphoma patients, and 3 are the patients with DLBCL or mantle cell lymphoma. Why is the response rate not as high as we've seen with other IgG-based bispecific antibodies? I think it's a little bit too early to really comment on the efficacy, just because it entered into the clinical development much later than other bispecific antibodies. The patient number is very small, and the study currently is still almost at the end of dose escalation. The expansion cohort will open very soon. We will be able to have a better assessment of the efficacy.
So to summarize, we've talked about several different bispecific antibodies that may have 1, 2, or even 10 CD20 binding sites. They have high efficacy with response rates in the 80 to 90% range, over 50% CRs in some of these studies. And we've got some interesting combinations with new drugs and older drugs as well, such as lenalidomide. And it seems like the efficacy is quite high. The balance is the cytokine release syndrome and navigating all of that. But that really brings us to, I think, the big question. So where you're quite experienced in using these drugs, follicular lymphoma, I always think of as very sensitive to kind of the risk benefit. It's, relapsed large cell lymphoma patients have very bad disease. They'll tolerate a lot of toxicity. Patients will if they need to, because the treatment, the disease is an unfavorable disease. In follicular lymphoma, we have lots of different options. And the tolerability really figures into patients deciding, do they want to choose one versus another. How do you see these fitting in practice? I know that they're not approved yet, and the indications may be specific, but if you could kind of put your crystal ball out and say, where is this going? Where would these be used in the future? What would your bet be?
Yeah, I think that in the immediate future, the first one to go to the finish line is really mosunetuzumab used for the third line and later use, based on this result from the pivotal phase 2 study. I really think that there's tremendous opportunities to incorporate bispecific antibodies into the management of patients with follicular lymphoma, with the correct education and the treatment plan for managing second release syndromes. The goal is really to give these antibodies in the outpatient setting and being able to offer it in the community. And we know even for patients on clinical trials, the incidence of second release syndrome and also the duration of second release syndromes is quite different than the same definition of second release syndrome used for CAR T cell patients. And with is a broader patient population that might be eligible for bispecific antibodies. I think it would really, and also the high efficacy. I definitely think it has it might change the landscape of how we manage relapsed refractory follicular lymphoma patients. Since looks like the conventional prognostic factors doesn't really correlate with the response to bispecific antibodies. So I think this is very encouraging. Of course, we need to do more clinical trials, and also with trials that focus on testing bispecific antibodies in earlier lines of therapy.
Yeah, I think that will be very interesting, whether or not they will fit into earlier, first or second line therapy when T cell function is probably better. But I would agree with you. I think it does probably push CAR T cells and follicular lymphoma a little lower down on the list for many patients. Yeah. Well, this has been a really great discussion, and I appreciate all of your insights. We'll finish up with some SMART goals, which are specific, measurable, attainable, relevant, and timely. And these include understanding ourselves, our peers, and our patients, the mechanism of action of these bispecific antibodies, CD20, CD3, discussing and understanding how to incorporate them potentially in the future in the treatment landscape, and also the issues around monitoring for and managing cytokine release syndrome and these particular agents. I'd like to encourage all of you to watch the companion activities where I'm joined by another outstanding faculty member. The first is entitled Determining a Patient's Risk, Identifying Rapid Progression of Follicular Lymphoma with Dr. Carla Casulo. And the second entitled Targeting Treatment, Selecting Optimal Therapy for Vulnerable Patients with Dr. Cami Maddox. Please visit the CME Outfitters Oncology Hub, where you can access additional activities on relevant oncology topics, as well as resources and patient education materials. Lastly, to receive CME or CE credit for today's program, please complete the post-test and evaluation. You'll be able to download and print your certificate immediately upon completion. Thank you again, Dr. Elizabeth Budde, for a great discussion, and I'd like to thank our audience for joining us today.